Right, I'm going to start the webinar. We've got a lovely number of people joined us already. Welcome to the Young Dementia Network webinar. I'm Tessa Guttridge and I'm chair of the network. Our presenters today are Dr. Janet Carter, Associate Professor in Old Age Psychiatry, University College London, and a Young Dementia Network Steering Group member, long term. Michael Jackson as well, Programme Lead for Neurology and Dementia Intelligence, and that's at the Office for Health Improvement and Disparities, Department of Health and Social Care. So welcome both. Joining us for discussion after the presentations are two commissioners, willing commissioners Helena Hounslow and Sheila Fletcher, and they'll join us a little later. We'll have time to answer your questions. Very much would love you to be putting questions into the Q&A function so that we can find them easily. But other than that, do use the chat function for any other messages that you want to share with everybody. The Young Dementia Network is a community of people with young onset dementia, family members and professionals. And as such, we always want to include a personal perspective. So I've invited Wendy Mitchell in conversation with Catherine, our Young Dementia Network coordinator. We've invited Wendy to offer her thoughts on why numbers matter. Can you run the film, please, Catherine?
I'm really pleased to be joined here by Wendy Mitchell, best-selling author, blogger, and member of our Young Dementia Network Steering Group. Wendy was diagnosed with young onset dementia at the age of 58, and since her diagnosis has worked to raise awareness of young onset and written 2 best-selling books based on your experiences. So today, our webinar, Janet and Michael will be discussing the recent prevalence data that estimates that 7.5% of people currently living with dementia were diagnosed under the age of 65. This is higher than the prevalence figures we've had before. So Wendy, why do you think it matters to have a better understanding of the number of people living with young onset dementia?
Well, if you'd pardon the pun, it's a no-brainer. Why would you not want to know how many people you have in your area with young onset? Otherwise, how do you know what services you need to provide? To know the figures more accurately enables commissioners to make best use of their money, their finances, because young onset, those with young onset need so much different support than those of an older age, because they're working, they have mortgages maybe, they have young children. They have far different needs than those in the older age group, which are just as important, but young onset is just as important as well.
Absolutely, absolutely. And the prevalence data was obtained from a review of GP records, looking at diagnosis date and the age at diagnosis. There are many different things that can have an impact on what happens during the diagnosis process. And this can affect the number of people getting a diagnosis. What changes would you like to see in terms of the experience of diagnosis for people with young onset dementia?
Well, my advice actually costs nothing. My advice is the best thing clinicians can do is to change their attitude towards diagnosis, to change their attitude from concentrating on what they can't do and what we can't do, and instead using their skill and expertise to diagnose young onset, but then concentrate on the person in front of them and concentrate on what they can still do, not what they can't do. Because to receive a diagnosis is a devastation for anybody, but it's the way you deliver it that can make or break that person. And to deliver it with hope instead of despair will give someone such a better feeling of a life still to be lived instead of a life being over.
Absolutely, that's so important. I think that is key, isn't it? Giving somebody hope when they're diagnosed.
The medical model of diagnosis concentrates on what we can't do, and also concentrates on what the clinician can't do. There is no cure.
Yeah.
So to find the balance between the clinical and a social diagnosis would be far better for the clinician because they're offering hope, and far better for the person because they're receiving hope.
Yeah, that's a really important message, I think. So last question, how would you like to see service developers, commissioners make use of this more accurate data in the future?
Very simply, by acknowledging we exist. Currently, it's a postcode lottery of whether commissioners acknowledge our existence and therefore provide the correct services. By acknowledging we exist, they can see the need for the services.
Absolutely. What message would you give to them?
That we have a very different needs. To ask people already diagnosed, what would you have wanted when you were diagnosed that you didn't receive? Don't be afraid to ask. You have the young dementia network full of people with young onset dementia. Use that resource. Don't think you know the answers. You're the experts by financial experience. We're the experts on financial need.
Absolutely. I think that's a really important message for people to take away, isn't it? Speak to the people with young onset, obtain their views, see what they need, what would they like to see change, what services do they need, what experiences would they rather have had when they had their diagnosis.
Absolutely.
Well, thank you very much, Wendy. Thank you for sharing your insights and experience today. It's been lovely to chat with you. Thank you.
Thank you.
So Wendy never fails to amaze me how absolutely on point she is every time, and you know, words of wisdom every time as well. So up next, I think is we're going to hand over to Janet. So if Catherine could share the presentation, that would be grand. And then, yeah, lovely. Thank you so much.
So thanks so much, Tessa. And yes, I just wanted to echo Tessa's thanks to Wendy for her insightful and knowledgeable comments and for heading up the webinar today. And as always, Wendy's a very difficult act to follow, but Michael and I are going to do our best. So what we intend to do really is to build on quite a lot of what Wendy's already said. And we want to explain our thinking behind the work that we're presenting today, which is why we wanted to obtain real world data about the numbers of people living with young onset dementia. And the overall theme, as probably most of you know, for the whole of the webinar series is about improving diagnosis. So I'm going to start by providing an overview of some key issues in relation to diagnosis and hopefully help explain why numbers matter. And then I'm going to hand over to Michael, and he's going to hit us with some hard data and some key figures, and he's going to explain the implications of our findings. So first slide, please. Thanks, Catherine. So I guess one of the key things to start off saying today is that if we ask young people and their families who are living with dementia in research or national surveys, one of the things they tell us about their number one priority is that improving diagnosis is essential. And I want to come on and think a little bit together with you all about why that might be. And next slide, please. So if we think about the experience of young people about to receive a diagnosis of dementia, there are a number of key points on the pathway to getting a final diagnosis. And if we look at the average delay to diagnosis for younger people, we know from all the research data that it takes about 4.5 years for a young person with dementia to get a diagnosis. And that compares to about 2 years or so for somebody with late onset dementia. And that's regardless of the severity of dementia and regardless of the cause of dementia. So you can see that there is a clear inequality in timely diagnosis for young people with dementia compared to those with late onset disease. And one of the things we might do is look at where we think there might be some key bottlenecks in the trajectory towards getting a diagnosis, which I've tried to demonstrate in the little schematic on the right-hand side. And so one of the things clearly in order to receive a diagnosis is for a younger person and a family member or friends to recognise that they may have symptoms which indicate a possible diagnosis. And clearly that may vary depending upon the diagnosis type and the symptoms that present as to when a younger person presents to their GP. That's a variable construct. But beyond that, when somebody reaches the point of their GP, I guess the first thing we hope is that the GP will recognise the relevance of some of the symptoms that a younger person is presenting. In other words, identifying some key red flags, which may make them think, I need to think about referring this person on to a specialist. And we know that at this point in the pathway, often GPs struggle to recognise key symptoms for a variety of reasons, because there's a lot of overlap with common conditions that appear in later life, mental health conditions like depression and anxiety, for example. And because of that, and perhaps because of under recognition of those symptoms, very often people experience multiple assessments. So GPs might refer to multiple different specialists. We also know from the evidence base that most people on their trajectory to getting a diagnosis may see a variety of different specialists, often usually 2 on average, but some people seeing up to 5 different specialists before they actually get to a point where they can have contact with a specialist who has expertise in the diagnosis. What we also know at the point of reaching a service where the diagnosis can be delivered is that from a large project called the Angela Project, which was conducted recently, we know that about 80% of people who were involved in that project with young onset dementia were actually seen in all age memory services. So they weren't seen in specialist young onset services, they were seen in all age memory services. And we know that within those services, that often specialists, perhaps because they see fewer people or because lack of training, they may struggle to identify the complex symptoms that characterize young onset dementia. But furthermore, also people in those services or clinicians in those services may not have access to the resources that they need in order to make that complex diagnosis. So we know that there is lack of provision of, for example, genetic services, appropriate imaging services, and some services may not have expertise in using the sort of specialist tools, cognitive assessments that are needed to make a diagnosis. So to summarize, we can see if we look at the pathway to diagnosis, why there might be inequalities for younger people in getting a timely diagnosis. Next slide, please. So if we wanted to summarize that, we might look at some key areas where we think we might be able to help to provide some key bits of knowledge that might improve the situation. And if we think about improved GP knowledge, for example, what I guess we want to do ideally is to tackle an understanding of red flags that might signify young onset dementia and help GPs understand how it presents, and most importantly, therefore, who should they refer on appropriately. We want people to get a diagnosis at the right place and at the right time. We want them to avoid multiple assessments. And that means it's helpful to understand, are there local and clear pathways for young people presenting to GP practices in order to help them reach the specialist that they need? hopefully a named specialist who has expertise in diagnosis of young onset dementia. And then finally, very much to reflect on what Wendy's already highlighted, we're not just interested in the whole process of getting to a clinic and seeing a specialist. We're really interested also in the quality of the assessment that young people are experiencing. So yes, we want to know, is the service using appropriate tools? Do they have access to investigations and genetics? But also, we hope that the services are delivering real quality and good practice in the assessments that they're making. And we would hope that people who attend the services are feeling listened and informed, that there's a practice of shared decision-making, and also that there are practical arrangements which allow young people, for example, who are working, or carers who are working, in order to be able to attend appointments at times that are convenient to them. So lots of different things that we could summarize, that we could think about, might improve the whole process of diagnosis. Next slide, please. So just to reflect back on the Angela project, which I mentioned earlier, one of the things we actually did in the Angela project was to try to understand from young people who've been on the receiving end of a diagnosis, how that experience felt. So we asked them, what did it feel like when you were given a diagnosis? And people were able to comment very insightfully on what we might call relational aspects of care, which Wendy's already highlighted. And what we mean by this is really, do people feel informed? Do they feel listened to? And what's the quality of the communication that clinicians make? And I've just highlighted on this little summary slide some of the key things that people told us when they were on the receiving end of getting a diagnosis. Some were in relation to the compassion and empathy expressed by the clinicians. Others were about feeling included and shared decision-making, and some practical issues about having opportunities to talk separately, for example. Next slide, please. People also told us a little bit more about the functional process. So this is just, as I said earlier, that when a clinic is providing services for younger people, even an all-age service, what are the key elements in terms of the process that could be considered to help improve the experience for the individual? And that might be, for example, follow-up letters. It might be about appointments at convenient times for working people. It might be about having a key worker as a single point of contact through the whole process. Next slide, please. So for those of you who are interested in learning a little bit more about some of the key points that I've made, and about really some summaries of the key data from the Angela project, work that the Angela team have done with the Young Dementia Network, I just wanted to highlight that there's actually quite a lot of valuable resources out there on the Young Dementia Network website. So these are compiled as a basis from some of the evidence that we've accumulated, which may be relevant to people who are working in services. For GPs, there's an excellent guide about diagnosis and helping them identify red flags. We have a good practice guide, which is based on a lot of work from the Angela project. And because there's not a great deal of information about NICE in the NICE guidelines for dementia about young people with dementia, we've also produced a supplementary document to support NICE guidelines for young people with dementia, as highlighted on this slide. Next slide, please. And also for those of you who might be working in all-age memory services, there's a couple of key resources, some checklists for people and for individuals and families about improving the experience, what your expectations should be, and also for people in services, a checklist for healthcare professionals about the sort of service that you might want to provide and how to do it. So next slide, please. Thank you. So just returning to the issue of diagnosis again, obviously one of the most important aspects of getting a diagnosis ultimately, of course, is that it enables you to get access to support, services, and the treatment that you need. And again, from the Angela project, this is just to summarise what we know about the current picture of support for people with young onset dementia after diagnosis. And I've just summarised the figures on the slides for you. And this is from the people who took part in the survey. This is what the people in the survey told us about their experience after diagnosis. So they told us, for example, about 40% of people with a diagnosis hadn't received any service in the previous 6 weeks after they had a diagnosis. 40% hadn't seen any healthcare professional within the previous 3 months. This is all pre-COVID. 60% of people had no key worker, 70% had no care plan, and about 46% of young people with dementia hadn't attended any dementia-related activity in the previous 3 months. And about 70% of family carers who were caring at least 5 hours every day hadn't attended any carer support group. So that's a reflection of the current picture at the moment about services that are available after diagnosis for young people with dementia. So next slide, please. So I don't want to leave everybody with the impression that all services are negative. And I want to provide a sort of counterpoint, if you like, to that argument, because of course, many people told us that they were very satisfied with the services that they were getting. They could give us some very positive examples of services. And of course, we know that there are some wonderful services out there doing a fantastic job. And in the Angela Project, we asked people to tell us about services that they perceived as positive. And we asked them to help us understand, why were those services perceived as positive? What were they doing well? Because this enables us to start to build a framework of good practice for the services that are out there. And what people told us was that the services that were positive were those for younger people that gave them a sense of identity, empowerment, and autonomy. They allowed them to be themselves, but to have available the support they needed when they needed it and when they asked for it. And for people who were in a caring or supportive role, the services were perceived as positive if they allowed them to fulfill their role as a carer or supporter, but also to be more than a carer. And on the left-hand side of the slide, just highlighted in the yellow boxes, it tells you what it was that those services were doing, which made them perceived as positive. And they were services predominantly that had knowledge and expertise in young onset dementia. They were able to provide very specific advice and information, which was relevant. They allowed people to access age-appropriate services, and they allowed people to have a voice. So they were also help people to have a positive outlook, retain normalcy, and maintain their sense of identity. So we're able to build on all this work and this very strong evidence base about how you might start to develop a framework of good practice for services for young people with dementia. Next slide, please. So what I've said is that we actually know quite a lot about what we need to do to help improve diagnosis. We know what services out there are seen as most helpful. But despite that huge evidence base, we still know that service provision remains poor. So why do numbers matter? Well, from our point of view, our experience, we think that having appropriate numbers, despite all this knowledge, means that we're able to tackle some of the inequalities that I've already highlighted. It helps us to lobby to raise awareness. It helps us to challenge existing beliefs about the numbers of young people with dementia. Because at the moment, change is hard to realise because numbers are dismissed as being too low. So I'm going to hand over to Michael now, who's going to talk a little bit more about the data and the work that we've done about prevalence figures.
Thank you very much, Janet. Do you want to, next slide, please? Thank you. My name is Michael Jackson, and I'm going to talk a little bit about 3 areas around the data. So what data is currently published on dementia diagnosis, the challenge presented by young onset dementia data and our study findings, and then a suggested approach to how people can calculate their own numbers in the project. So that's what I'm going to cover. My starting point for this work with Janet really was going back a couple of years in a sense of a conversation was around, not being able to count the number of people with young onset dementia, of which I pointed out that there was a data set available. And the question came back was, what about people that had dementia, a diagnosis of dementia before the age of 65? What happens to them when they become over 65? And that's where we sort of we got to. So before I get so much into detail, I guess one of the things I'd like to say thank NHS England for their support for us to be able to do this work, to understand and exploit the sort of data that we've been able to access, and enable this project to work. So next slide, please. So current data, there is data currently published on dementia diagnosis monthly by NHS Digital that gives a 5-year age bands at England level and for the CCGs over 65, and then at primary care practice, data is published for the under 65s and over 65s. This data is published based on an extraction from primary care systems by current age, and therefore the young onset dementia count is just limited to the under 65s, which we've said before. So this approach of using current age does cause us to lose sight of the people with the diagnosis prior to 65, and exactly what happens to them beyond that. Next slide, please. So what does the current data say? The current data tells us that there's 14,700 people with dementia who have diagnosis under the age of 65, which is roughly around 3.3% of all people with dementia as at August 2022. When we look at the data, I think it sort of reveals something interesting, certainly something Janet said earlier about the diagnosis process. Of the 6,400 practices that submitted data, what we find is about 24% of practices have no cases under the age of 65. There's only 14% of practices have 5 or more cases of people under the age of 65, which is around 900. But nearly 2/3 of practices have 1 to 4 individuals on their books. So certainly that issue around the rarity of cases, and it's more to do with being able to remember how you deal with them, perhaps, because there's such few cases. Anyway, so what these numbers illustrate for me is about the sparsity of the distribution. As I said, about 2/3 of primary care practices have fewer than 5 cases under 65, and so provision of services could be difficult for so few people. And if you think of the competing pressures there would be within primary care practices that they operate. So the thing that sort of occurred to me looking at this data was perhaps the base unit is perhaps is too small. So primary care practices are too small for planning services, and perhaps it's worth a consideration of actually looking at other levels. For example, primary care networks, being able to plan services at primary care network level or above, that would give you a little bit more a critical mass, critical numbers rather, in developing services. Okay, next slide, please. So where does the current data come from? It comes from primary care, and under the QOF outcome, the Quality Outcomes Framework programme, primary care practices are required to maintain a register of people diagnosed with dementia. Another aspect through a core contract is that data is actually extracted from primary care practices and enable NHS Digital to publish the data on a monthly basis. The data is extracted using around 149 codes, which is SNOMED codes, for describing what dementia is. So that's what's used as the extract. Next slide. Thank you. So, I mean, in essence, in this situation, if a diagnosis isn't recorded on the primary care system using the right codes, then it is not counted in the extract. So, if it's not there, it can't be counted. Next slide, please. So what I just wanted to sort of illustrate here is something around the weaknesses in the data collection processes. There are probably many other ones, but these are the two that sort of focus in on me. And I think some of the issue around this is do we do all cases that are diagnosed, do they get onto primary care systems? So the first potential weakness in the system, I think, is around the diagnoser and their sort of communication with primary care. And from a diagnoser perspective, do people use SNOMED codes that describe the cases when they're communicating with primary care? There's 149 codes that I've mentioned already that are used in the extract, 18 of which have the term early onset or pre-senile included in them. Again, is that adequate? Is that adequate to describe the cases? And also, is there a process in place that enables people to communicate with primary care? Is there routine communications? Certainly in memory clinics, I know they're very well versed in communicating with primary care practice, and these things are set up. I guess some of the question looks at where diagnoses occur other than memory clinics. If the diagnoses occur in non-memory clinics, do people understand the mechanism that needs to capture the coding, etc.? And on the receiving end of all this communication, I guess it's primary care practices, and in a sense of how many diagnosis cases actually get coded on the system with the specific codes, and it's understanding that relationship between the diagnoser is the communication flow. So next slide, please. So one of the things that sort of comes to me is actually, are we making sure that all the people, the cases that are diagnosed are actually on the computer system? So, you know, our process in place locally to ensure that our outcome is desirable, as in all the cases are being diagnosed. So what we'd like to do, next slide, please. What we'd like to do is give you the opportunity, if you've got any good examples where there are processes in place that checks this mechanism, or alternatively, are these things major problems in your space around capturing diagnosis? So if you have any comments to make at this point, we will pause for a minute while people answer this. And I suppose the other angle of it is people with dementia themselves. You know, have they had any experience of trying to get their diagnosis registered with their primary care practices? So be on the clock now. Thank you. If you want to have any comments, please put them in the chat.
Minutes up, Michael.
Thanks, Tessa. Next slide, please. So thank you very much for your contributions. We'll review those and bring them back into the conversation later. So moving on to the project work that we did, trying to investigate that. So the challenge we had was that we need to be able to count, to get the full picture of the young onset dementia diagnosis. We need to somehow estimate the number of people that are over 65 years of age that had had a diagnosis beforehand. The approach we had was looking at both age at diagnosis and current age, rather than just the current age, which is where the data is extracted. So what we were able to do is we queried the Clinical Practice Research Database, CPRD, which is a sample database, to be able to work out the proportions of each current age group and when they were diagnosed. So we came up with a model for the data, and then we applied the data, the model to the monthly data stats based on the current age. So that was our approach. Next slide, please. Thank you. So what we found was that in total, 7.5% of the population with dementia had a diagnosis prior to the age of 65 years of age, which we reckon there's about 33,300 people in England. So what we were able to estimate, in essence, was that 4.1% of the 65 plus population would have had a diagnosis prior to the age of 65. When we looked at our approach to sort of benchmark to see where we how good our, I suppose, approach was, and what we found was that the young onset dementia diagnosis prevalence was 92 people per 100,000, and that's the population based 30 years and over. And so what we need to do is understand how does that compare. So we had two studies that we compared that to. The previous, the Harvey study for the UK estimated that 54 people per 100,000 had young onset dementia, which is quite a lot lower than our figure. But also the worldwide study, the Hendricks study, estimated that 119 per 100,000 people would have young onset dementia. So we were somewhere in the middle. And I guess without really being able to look at all records, we wouldn't be able to estimate the true number. So we felt that it was reasonable within those sort of contexts. Next slide, please. So effectively what we were able to do, I think, is work out from each particular age group what proportion of them were young onset dementia. So as this slide tells you, so when we're talking about young onset dementia, so it's 100% of the under 65s with the diagnosis. It's 55% of the 65 to 69-year-olds with the diagnosis. And then for the 70 to 74-year-olds with the diagnosis, it's 15%. And then for the 70 to 79-year-olds with the diagnosis, about 4% of those cohorts. There were people that were older that were registered with allegedly young onset dementia, but I think there's potential data quality issues there that we, with our access, perhaps potential access to all the records, it would be a better way to estimate that. But we were happy with these numbers. Next slide, please. So what's going to happen next? So there's no immediate plans to generate some national data sets that include the current onset dementia for the time being. So an opportunity, I guess, is to perhaps come up with some alternatives. And one of the alternatives would be, I'm aware in some geographies, there are arrangements, agreements for GP practice data to be accessible to the local system. And one of the opportunities there would for people to actually do the queries themselves on primary care systems to come up with this. So that's one potential solution. Another potential solution is that with potentially come for those areas that don't have that access is some indicative numbers. And I'm now going to talk you through a couple of slides that hopefully might help you in the process of estimating it. So next slide, please. So I've got two slides that talk about two geography sets. This one talks about CCGs or integrated care systems that we're currently using. The other slide talks about primary care practices. So the ambition to calculate this is all the people with young onset dementia. So there's two groups, as we've said before, the under 65 group, and then there's the proportion of the over 65 group. The hyperlink in this slide takes you to where the data is in NHS Digital. These slides will all be circulated so people can, if they wish, use them to click through and do their own calculations. So next slide, please. So when we're looking to calculate the number that are currently under 65, the data isn't clearly isn't easily available. So one we'll have to do is manipulate the all age data because the all age data is available and the under 65, the over 65s data is available. So taking one from the other will give you the count for the under 65s, and that's the data, the file. The summary file will give you those data with those particular tables with the related numbers. Next slide, please. So to try and calculate the over 65s, the proportion that are young onset dementia. So what collectively we want to do is look at the ones that are 65 to 69 that have got young onset dementia, the ones that 70 to 74 with the diagnosis of dementia that are young onset, 70 to 79 with young onset, and add those together, and that will give you the over 65s with young onset dementia. So as we found earlier from our study, that 55% of the 60 to 65-year-olds with dementia are likely to be young onset. 15% of the 70 to 74 are likely to have young onset dementia, and then 4% of the 75 to 79 with dementia. So it's a way of estimating the number of people over 65. So again, there's a different file at the bottom, hyperlinked to where the data is available to do that transaction. And so adding the yellow box and the salmon box together will give you the total number for the young onset dementia, which is what was required. Next slide, please. So this slide just talks about primary care. So again, total number with young onset will be the under 65s plus the over 65s that are young onset dementia. So the over 65, the under 65s are 100% off, and the value that you need to apply to the over 65s will be 1.4% of the current over 65s at practice level. Will give you the estimated number for primary care practices. There's a caveat coming with this, is that I've illustrated earlier that numbers are small in primary care. So I guess this is an indicative way of looking at the sort of numbers. Perhaps, as I said before, primary care networks might be a better geography to operate at. So I hope I didn't put too many people to sleep with those last two slides, but they're there for reference. And if you move on to the next slide. So moving to conclusions. So yeah, from the study, we were able to estimate that 7.5% of people with a diagnosis of dementia are young onset. In essence, what we managed to do was estimate the 4.1% of the people over 65. Part of the conversation, part of the presentation is around how data is collected. And in essence, if the diagnosis isn't on the computer system with the right codes, then it's not counted. There's perhaps opportunities to improve that process. And some of that, I think, is looking at the interface between diagnosis and how primary care teams work. And the last one really was last bit was just really what occurred to me. And it's just sort of a rally cry to people with dementia. And really it's make sure that your diagnosis counts twice. And what I mean by that is clearly getting a diagnosis that perhaps might be take longer than should do, and that should hopefully give you support and services. But it's also important that you insist that actually it's put on the primary care record in the right format, so it can become part of the statistics, so it can be part of planning, and you're in the system formally. So that's really just a battle cry for you as a suggestion. So if I can hand back to Janet, next slide. You're on mute, Janet.
Thank you very much. One of the hazards of webinars. Thank you so much. So I'm just going to wrap up. So thank you so much for your attention today. But I just wanted to leave you with our final slide. And this is really to go back to the slide that I presented a little bit earlier. And just to get us thinking a little bit more about services and support and provision before we hear from the commissioners on the panel. So I guess if you look at the way that this data is presented on this slide, I suggest that there might be two ways to interpret this data. The first way of looking at the data might be that actually services are available for young people with dementia, but they're just not using them because they don't meet their needs. But the second interpretation, of course, is that there just aren't any services available for young people to use, and those services are not provided because numbers are low. So we might call this a sort of chicken and egg situation, really. And I think we're going to hear a little bit more in the panel discussion about an interpretation of the data and how we might commission our way out of it. So thank you. That's the end of our presentation. Thank you for your attention.
Thank you very much indeed, Janet and Michael. That was absolutely packed full of information, and I think it's one of those presentations that you need to really look at later and have a real mull over. But thank you for that. May I invite Helena and Sheila to now join us on camera and unmute yourselves. Thank you very much. So just to introduce Helena Hounslow, Mental Health Programme Manager, NHS, Lancashire and South Cumbria Integrated Care Board. Hope that's correct. Hello,
yes.
Helena.
Hi.
And then Sheila Fletcher, Commissioning Manager, Mental Health and Vulnerable Adults, Humber and North York's Health and Care Partnership. Welcome. We asked these willing folk to join a panel to give some thought to just spend a short time offering your opinion, please, on the state of young onset dementia services and your own experience locally, just from your own point of view, really.
Should I go first, Tess?
Helena, thank you.
Okay, so thanks everyone. Yeah, so as Tess said, I'm leading on a review of older adult mental health and dementia services for Prevalence in South Cumbria. And one of the areas that I wanted to sort of understand as part of this work is what is the current provision for individuals receiving an early onset dementia diagnosis. When I accessed the data that we hold as a system, it was evident to me that although the diagnosis rate was there and recorded, there wasn't a breakdown of the age ranges for the people receiving the diagnosis. So I've worked with our mental health provider who provides the services, and they've then broken down the age range for us so that we understand that anyone receiving that diagnosis, what age range they are. So that would give us a starting point as to understand what sort of need is for our patient population. The working group that I chair, we've also done, and we're still working on it, a gap analysis of post-diagnostic support, not only for the individuals receiving the diagnosis, but for the carers. And one thing that came quite apparent to us was there was very little, I know of one group in Lancashire, South Cumbria for early onset dementia. And having read all the guidance and the documentation that's out there, it came really clear to me that it's a massive gap in our area, because I think the needs and the support that's required for that group is quite different for people post sort of 65 plus. You know, as Janet mentioned early on in her presentation, you know, that you're working with, or I think it might have been Wendy actually when she was doing the presentation, you know, you've got people of working age, you've got people with young families, mortgages, a lot of different sort of complex sort of situations to work around when you receive such a traumatic, I suppose, diagnosis. And I think we need as commissioners to ensure that we commission services that are relevant for that group, as well as for the older age range as well. So yeah, so I'm currently working on that, and I think it's about, we need to understand the numbers, and we need to ensure that we listen to the individuals of that group and understand what they want. And I think it was a really important point that was raised earlier around not just it's about obtaining the information from the people that have been on that journey and what they would have liked to have received, but also with using the information that we've got, ensuring that, and the data that we've got, ensuring that the although they're relatively small numbers compared to the wider dementia diagnosis rate, that we look at different possible approaches, whether we look, I mean, I work in like the South Cumbria on the Fylde coast, but there are other areas next to us, Cheshire and Merseyside, where numbers could be, you know, that's more or less the same. So why don't we commission services across a wider footprint for a cohort of individuals that should be able to access support services and advice and guidance. So yeah, that's the work I've done up to now.
Thank you for that. Sheila, could you respond to the same question around your opinion about state of young onset services and your own experience locally?
Yeah, so I've been involved in dementia work for quite a few years now, in what was formerly the Vale of York CCG and is now the York Health and Care Partnership as part of the Humber and North Yorkshire Health and Care Partnership. And that was initially first because diagnosis rates were and continue to be low. Probably a couple of years ago, we commissioned dementia coordinators from a very trusted third sector organisation, Dementia Forward. And the dementia coordinators have become real experts in what we call case finding, and a huge support to our GPs and primary care in looking through clinical records and looking for people who have a note of memory in their clinical records. So that was one thing. But secondly, over the last couple of years, we have developed a dementia strategy. And that has been done through really close working across health and social care with the statutory and voluntary and third sector organisations. So I feel very fortunate to have made some relationships with some really key people who are working across dementia services in the area. And young onset dementia is intrinsic to our strategy, but as Jill Quinn, who is CEO of Dementia Forward, would say, young onset dementia needs its own toolkit. And whereas it's intrinsic, I think we feel that we must do some bespoke work around young onset dementia. And Dementia Forward are a key partner with us because they are running a campaign called the You and Me campaign around young onset dementia. So it has provided us with a huge amount of support that we can tap into, really. As Helena has said in your previous presentations, we do have a gap in our local data, and we do need to do much more around that. Again, I'm really fortunate to be able to work with the Humber and North Yorkshire Integrated Care Board, who are working in a way that improves population health and reduces inequality. So there is a dementia steering group there. So working with them to hopefully our strategy will dovetail with theirs. But in terms of the young onset dementia work, I think our priorities are that to increase awareness. And that's not just around awareness with our GPs, although that is really important. It's around changing attitudes, which I think Wendy mentioned right at the start, and the You and Me campaign will be really important around that. But in terms of raising awareness for our GPs, it's working with our dementia coordinators who can help GPs identify those red flags for people presenting with young onset dementia. And then working with colleagues in the memory service to have a quality assessment for people with young onset dementia that includes all those aspects that Janet mentioned earlier about a specialist neuroimaging, perhaps a specialist neurology assessment and psychology assessment. That happens already, but that may be as a consequence of either through a multidisciplinary team meeting in a memory service that they may refer people on for that. It's not, we don't have a very specific pathway around how that might happen. And then, of course, post-diagnostic support, which covers the entire pathway. And why is data important? Well, we know that prevalence is increasing. We know the economic impact of that and the increasing dementia and the human impact, the impact on people with dementia and their families. And also just around raising awareness around prevention. I think we've heard recently that 40% of dementias could perhaps, behaviour could perhaps influence those. So it's about, data being able to help us understand that. But we're hoping to run a very small population health project in York And that's using the RADAR tool, which is an acronym for something very long and technical around rapid data interrogation or something like that. But it's a health intelligence tool. And RADAR tells us in the city of York currently that it suggests that there are 174 people with a diagnosis under the age of 65. NHS Digital tells us there are 62. So we know the coding's not right, which is, Michael was suggesting that, and it could be that NHS Digital may not be counting old codes. So we're constantly, you know, trying to cleanse our registers and cleanse our data and do this reconciliation. So yeah, a challenge would be, you know, can we have a dashboard that is much more accurate, that gives us that information much more easily? But what we are able to do, and what is going to be part of our strategy and an action for us, is that RADAR can identify vulnerable populations with a diagnosis of dementia under the age of 65. So that is through ethnicity, indices of deprivation, some long-term health conditions, learning disability. So, you know, we can risk stratify that and look at those various conditions and the corresponding data, and maybe that will help in identifying red flags in future. So there is some work going on. A challenge for us is, whilst we are being able to do that case finding, the challenge is the long waits in our memory service. And I understand this is a national problem. For us, it's because there is a growing number of referrals because of the excellent work done by dementia coordinators. And the bottlenecks and the long waits in the memory services are still a legacy of COVID, and working through that backlog of people who might have put off their assessment during the pandemic. So some opportunities there, I would say, but also challenges for us, which I'm sure are probably shared across the country. Thank you.
Thank you. That was a very comprehensive response. I think you probably both partially, if not quite fully, covered the how do you commission out of this situation. I think you probably have covered that. Helena, did you want to add anything in terms of commissioning out of the situation that we're in right now?
Sorry, I couldn't get off mute then. I think what Sheila has sort of talked about really is around linking in with our public health colleagues and understanding what tools we can utilise to really cleanse that data. Because until we understand the numbers, we can't evidence the need to commission services at level. So I think that is so essential for us. And I think it's working with our GPs as well and our primary care colleagues to make sure that they've got a clear understanding of the importance of the appropriate coding of the services, and working with our MAS colleagues as well to ensure that they've got systems in place to ensure that they're communicating clearly with primary care. That's the starting point for us, I suppose, and then understanding and listening to the individuals and the carers of what they need, what they feel they need post-diagnostic. And also, I suppose, one of the areas that I've been considering is what happens sort of pre-diagnosis, what support's available for individuals as well, which I think is a gap. And I think I should imagine it's quite a hard time for both the individual and their carers and family members to sort of, there's a gap there in support that's available and advice. And so I'd welcome sort of any input from individuals to sort of suggest what would be best for that period of time as well.
Yes, I think you're right to identify that, because it must be a very, very tough time and have all sorts of impacts on relationship, work, you know, family. We've just got one more minute on this, Sheila. Did you want to add something?
Yeah, I was just going to say, Tessa, that We are able to refer people pre-diagnosis now to Dementia Forward. We commission them as our post-diagnostic support from the memory service, but we are now able to refer people pre-diagnosis, and they Dementia Forward have a helpline, and I understand that does include specialist advice for people with young onset dementia, and for people who do receive a diagnosis, there are various activities, age-appropriate activities for people with young onset dementia. And we're also commissioning hub clubs. So we've just recently commissioned the 3rd hub club in the city for the City of York, and I mean these are for everybody with dementia, but obviously the Dementia Forward hold, I think they've got about 3 for young onset dementia as well, which provide more age appropriate activities. But yeah, that pre-diagnostic support, feedback from our engagement was that it's absolutely crucial.
Yes, and in the chat there's some links to some support, pre-diagnostic support. So I think what we'll do is we'll make sure that we pull the chat together and share that in the follow-up email as well.
Thank you.
Just so that everyone's got those really useful links, and of course the feedback on the question that was posed. I'm going to move now to the Q&A, and I'm going to pick out the questions now. We've got about 10 minutes on this, and we've got 7 questions. So first off, from Rebecca, how does the data work with the ICBs rather than the CCG system? Is that one for Michael?
I'll come off mute. I mean, in terms of the registrations, it's all nested. So yes, a majority of ICSs are an aggregation of CCG geographies, I guess. So it should be readable up and down. Okay. I mean, if I haven't put that on my slide, if that's what the question is, can I do some a calculation slide on ICSs? If that's what's needed, then yeah, that's fine.
Excellent, thank you very much. Next one from Gemma. Is there or will there be an accessible dashboard for young onset dementia diagnosis in the way that there is for 65 plus? And why is under 65 onset not captured or measured in the long-term plan ambition? Would that be Michael in terms of the dashboard?
Is that me again? I mean, in terms of, I guess there isn't a dashboard at the moment, and I don't really think there's plans for a dashboard. I guess the issue there is there needs to be an ask for it, and I guess some of the question is that needs to be raised with within the mechanisms. I'm not quite sure exactly how we would raise it, but whether there's colleagues on NHS England could comment on that. Perhaps it's through the Dementia Clinical Network route. And I do know NHS England are working on dashboards of types of different areas, but specific for young onset, I guess. Yeah, we're not sure at the moment. I mean, the point about the over 65s, I guess there's a bit of a mismessaging, perhaps. The reason why the over 65s, including the estimated dementia diagnosis rate, was all to do with the under 60, the modelling of the estimated number of people with dementia, which is the denominator of the estimated dementia diagnosis rate. And the academics I understand the academics in Cambridge that developed the CFAS2 study, it was felt that the data below 65, because of the sparsity of numbers, created a lot of uncertainty about the modelling. And so it was excluded, not because it was picking on any particular group, it was just the data wasn't reliable enough. And so that's really fed into the estimated dementia diagnosis rate. So it's not that the under 65, the young onset, is being ignored. It's just the data aspect of it isn't reliable. How one approaches that, and I guess the issues about around data, the more data we can put in the system, the more reliable it comes, and the more the ability. So it needed a different approach than the one that I believe colleagues at Cambridge University. Yeah, I'm happy to be corrected if that wasn't correct from our colleagues, but that's my reading of the situation. So yeah, it's to do with the sparsity of numbers that caused the problem. That's why it was sort of taken out of the equation, if that answers that question.
Okay, thank you for that. I guess what we need to do, for all of us who feel that we absolutely do need these numbers and we need them to be as accurate as possible and delivered to us as routine, really, we need to get together, don't we, and make that happen, and put our requests in via the route that whatever's the right route, really, clinical networks, or let's find that out. So is the dementia pathway a statutory requirement for all NHS trusts? This is from Tim. It would appear in Mid-Essex that we don't have one unless you know to ask for it. So it is dementia pathway a statutory requirement for all NHS trusts? Who knows? Who knows? Whoever knows, could you? There's a bit of a shaking of head. Is that because there isn't? It's not a statutory requirement, or we don't know? Sheila?
The National Dementia Well Pathway, it came about from the Prime Minister's Challenge, I believe, and it was preventing well, diagnosing well, living well, supporting well, dying well. But it's not mandatory in any way. I think a lot of dementia strategies, including the one City of York have just developed, uses that as a framework. I mean, it's pretty comprehensive, and you see it a lot in guidance. But if that's the pathway that's been referred to here, it's not a mandated pathway as such. And then, of course, I think there's, health organisations have pathways in terms of a prescribed way into services. So I think it depends what they mean by pathways.
Okay, thank you. From Margaret, we use ICD and have a chart for the SNOMED equivalent to share with primary care. A few years ago, we checked our data, memory service data that was, against primary care and found that it was very different. So I think that's a comment, really. And actually, that's been found in quite a number of other areas, as well as Sheila mentioned that too. So moving to Melanie's question, is data from private hospitals captured in the same way as NHS practices? Husband referred to a neurologist at a private hospital, as the GP said that there would be a really long wait for the memory clinic. And I suppose that's a good point, isn't it? Does that then feed through into the NHS practices? Does anyone know that? I mean, one would hope that it would do, but
certainly, if I can take that in terms of data collection, I don't know the answer, but I would suggest that it depends on the referral back. For a referral letter back to GP practices, whether they code it in the same way, because the individual, I'd imagine, is still in the system, and it's whether the sufficient information, the sufficient set of codes are captured so they can put them on the primary care computer system. So I think it doesn't matter where the diagnosis comes from. I guess that's my answer, as long as it's coded, and perhaps if that route is being used, then perhaps that's part of the relationship between the diagnoser and primary care.
Yeah, okay, thank you. Is there any plan to estimate the prevalence of different conditions within the data set, the proportion of those cases that are Alzheimer's disease versus other conditions?
It's a very good question. The fundamental problem is that we don't have access to primary care data on a routine basis to do all the queries that we'd like to do it. There are potential developments around improving that in the middle term, in the medium term. I mean, part of the issue that I will say about extracting that is certainly if you compare the HES data set, for example, the decoding of dementia in hospital activity, there's a big chunk of it that says unspecified dementia. So I guess to some degree, it goes back to diagnoser. If the diagnoser can put their finger on exactly what it is, then probably there's a code for it. There lies a sort of, a conundrum. Is it as black and white as you can do that with? I'm a statistician. I'm not a clinician. Perhaps Janet might want to comment on that. But yeah, it's accessing the data is a problem, and we are working towards it. But it's also what we find in the data. All depends on how it's being captured and coded and submitted. Hopefully that answers the question.
Thank you. A couple of comments really. Susanna said there's so much to be done, and goodness me, there is, isn't there? So much to be done. And Lizzie points out that not everyone gets a diagnosis through memory clinics, often referred by neurology, as we know, and sometimes out of area, and therefore they may be missed and not picked up by local services. And that is the experience of quite a number of people, and they feel the lack of that support really. Sharon asks whether there's any way to distinguish those with a learning disability and dementia diagnosed under 65. I think we need to make that the last question. Can anyone help with that?
I guess just to come back, it depends on the coding again, really, I guess, because the question possibly may be directed at people who have Down syndrome, who develop Alzheimer's disease, because that might be a common diagnosis associated with Down syndrome as people age. So again, I guess it would depend upon what the coding is given and whether there's an appropriate coding to say that this is dementia in the context of Down syndrome, for example, or Alzheimer's disease related to Down syndrome, and what the clinician might write, again, as Michael's already alluded to, what the diagnoser writes as the diagnosis. So I don't think there's that specificity, unless Michael knows better, within the coding system at the moment that I can recall.
Okay.
I can't add to that, sorry. I haven't studied them that in detail.
Oh, you've done so well with responding to the questions. Thank you so much, and thank you to Janet and Michael and Helena and Sheila, and then also Catherine in the background, making sure that we can see everything that we need to see. There's a lot of comments and feedback and such like links in the chat, and as I say, we'll anonymize and we'll have a filter out and make sure that that's shared with everybody as well, because it's so useful. Other than that, I just wanted to let you know about the November the 16th webinar, which is picking up again on the experience of diagnosis, but looking this time at those pre-diagnosis symptoms and the GPs and red flags and such like. And it's a really interesting piece of work that from a couple of people in the Netherlands, and they've done some fabulous work for young onset over the years. So I think that's it for today. Many thanks to everybody for coming and for contributing, and look forward to seeing you all again on the 16th of November. There is a follow-up email, of course, with the link to the recording and everything else that we've mentioned. So thank you very much. I'm going to close the webinar now. Thank you. Thanks.
Bye-bye.
Bye. Bye.